So I'm delighted to talk to you this morning about one of my favorite topics, placebos and nocebos in sickness and in health. And today I'm going to be, I have no disclosures, and I'm going to give you a brief history of placebos in clinical trials and medicine, because I think it's really important to get the perspective of how we came to use placebos in clinical trials and how we use them in medicine today. One of the key drivers of placebo effects, which I'll talk about in a minute, is expectation. And expectation is a psychological phenomenon that gets transformed into neurological signals that then can mediate placebo responses. And I'm really excited to talk about what we've learned about expectation and placebo effects. They're also the opposite of placebos, which is nocebos. And that's when negative expectation leads to negative outcomes, increased symptoms, increased pain, and so on. So we'll touch briefly on nocebos because they're becoming more and more important, I think, in modern medicine. And we'll talk a bit about the brain on placebos and how genes and drugs modify placebo effects. And then we'll just summarize and think about how we use placebos and nocebos in clinical trials and medicine moving forward. So placebos got the name placebo from this quote in the Bible: "Domino in regionem placebo domino in regionem vivorum." I'll please the Lord in the land of the living. And placebos were people, hired mourners, who came to the funerals of wealthy patrons and basically simulated mourning. And it was thought that although this was much needed, because who wants to be seen having these emotional outbursts, it was also thought to be deceitful. And from the get-go, placebos get this kind of negative label and connotation. Placebos in modern times are basically sugar pills or dummy pills that are used in clinical trials, but they're also thought have a broader definition today. And sham surgery, sham acupuncture are thought to be forms of placebo. And we'll talk about both of these throughout the talk. What are placebo and nocebo effects? Well, placebo effects, that's the symptom relief or the salubrious clinical outcome that you get when you've taken an inert replica of an active treatment. Placebo effects are very specific to being administered a placebo, but we can't study placebo effects as you would think in clinical trials, because in clinical trials, there are a lot of other things going on, not just the administration of placebo. There's regression to the mean. People tend to come into a clinical trial when they're not feeling well, so they tend to get better. There's natural history, which thinks about the natural cycle of a disease. If you were to do a clinical trial, and one of the early ones was done in the common cold, within a week, everybody would probably get better. And so you couldn't really attribute the benefits of the drug or the placebo to the treatment. It's to the natural history of the disease. And of course, there are Hawthorne effects, which are the effects of being observed. When people are observed, they change their behaviors, they change their reporting. So placebo response, as we describe it in this talk, encompasses not just placebo effects, but these other factors that influence people's response to placebo. And as I mentioned, there are nocebo effects, which are negative clinical outcomes from inert treatments that are driven from expectation. And on the right here, we can see that expectations, conditioning, verbal clues, emotions, learning, contextual cues, and motivation can all influence placebo effects or placebo responses and lead to symptom relief. So let's go back a little in time and think about early placebos and early placebo-controlled clinical trials. So one of the earliest ones was done on animal magnetism, which was a method of healing developed by Franz Anton Mesmer, who was a physician in the mid-1700s. And he had this, what he thought, animal magnetic effect on people. And he thought that animal magnetism was this fluid that moved around us, and he could channel it to help people heal and become better. And his animal magnetism was so popular that he scaled it up. And that's the image below here with this instrument called a baquette, which was a large tub of water with metal rods coming out. And patients would sit, legs touching, gripping these metal rods, touching each other. And as they would, you can see, I don't know if you can see in the background, here's a person playing the piano. They would play these very kind of soft, delicate tones on the piano, and he would wave the wand, and people would literally fall into trances that were cathartic and curative, and he called them crises. And there would be screaming and fits of laughter as people would, come back to health. Well, this method of healing was so popular, it called the attention of the medical establishment. And by the time Marie Antoinette got involved, I think it was Louis XVI knew it was time to step in and have.
Kathryn, we lost you.
All right, so Marie Antoinette was a frequent baquette flyer. She was a proponent of mesmerism, and Louis XVI stepped in, and he engaged Benjamin Franklin to do an investigation of mesmerism. This was the medical establishment was very concerned at the level of popularity. Benjamin Franklin devised a really ingenious system, and here's a wonderful etching of Franklin on a horse kind of expelling mesmer. What they did was they created sham mesmerists and sham rods, and found that they had the same effect with the fake rods and people who were just pretending to do animal magnetism. And so this is very important, I think, because the conclusion wasn't that animal magnetism didn't work. It was that the sham or placebo magnetism worked equally well. And similarly, a few years later, there was another invasion of another therapy that this time in England grew to tremendous popularity. And this was the metallic rods of Elisha Perkins. And Elijah Perkins was a physician from Connecticut in the United States. And he developed this method from observations in surgery, where he noticed that when he touched muscle, people would have a muscular contraction when he touched it with metal. And so he developed these two metal rods, and he called them Perkins tractors, which was the practice of the time. When you invent something, you give it your name, you patent it, and hence the term patent medicine. So Elisha Perkins, and later on his son Benjamin Perkins, had tremendous success with this therapy. A pair of these rods sold for $500 back in the late 1700s. And again, the medical establishment was deeply concerned that these were, corrupting medicine. And John Haygarth, pictured here in the bottom of left of this slide, was a physician who would basically do another clinical trial on these Perkins tractors. Now, Haygarth was a student of William Cullen, and William Cullen was one of the great physicians of the late 1700s. He was the physician to the King of Scotland, and he wrote quite extensively about using placebos, and he's credited with one of the earliest people to write about placebos. And here's a wonderful quote from him: "I prescribe therefore in pure placebo, but I make it a rule, even in employing placebos, to give what would have been a tendency to be of use to the patient." So Haygarth, a student of Cullen's, knew about the placebo effect and was very fascinated with it. He also knew Benjamin Franklin, and he had corresponded with Benjamin Franklin about how to encourage people to get inoculations for smallpox. And so he was aware of the mesmerism trial and fashioned a similar trial where he made 2 wooden rods and painted them gold and silver and sent them out to friends and colleagues in England. And lo and behold, these sham rods had amazingly powerful effects. And he wrote this wonderful book of the imagination as a cause and cure of the disorders of the body, exemplified by fictitious tractors and epidemical convulsions. And this book would rival the book that Benjamin Perkins, Elijah Perkins' son, had put out, and would eventually really do away with Perkins and his tractors. But again, I want to point out that the conclusion from Haygarth's study was not that the tractors didn't work, but that sham tractors worked equally well. So to kind of fast forward over time in this history of placebos, once we get to the early 1900s, physicians are still kind of dueling it out with quacks and nostrums and tonics, because the only medicine that they were really offering was bloodletting, purging, and sweating. And these so-called regular physicians who were trained at medical schools really had a challenge, because nobody really wanted these treatments that were not particularly effective. And they kind of were more drawn to the treatments that had this powerful placebo effect. And unfortunately, these quacks, nostrums, and patent medicines also had very negative effects. For instance, there was the cocaine tooth drops, or cathartic pills, or another drug called Habitania that was used to treat addiction and contained heroin and morphine. There was also Lydia Pinkham's vegetable compound, which was tremendously popular, but was about 18% alcohol. So as we kind of move into the 20th century, some big ideas start to come into popularity in medicine, in research, and we see that the concept of a receptor in pharmacology takes hold, homeostasis in physiology, and metabolism and biochemistry. And now we start to more consciously design drugs. And by the end of World War II, we start to do clinical trials. But we realize that we still have this placebo effect that's coming along with us. And placebos are now implemented in clinical trials as controls. And in 1955, Henry Beecher, who was a physiologist at Mass General Hospital in Boston, wrote a very important paper called The Powerful Placebo, where he basically summed up all we knew by this time about placebos. And he estimated that the placebo effect was very powerful. In fact, he estimated that it was in about 35% of cases. And that number is, you know, people debate whether that number is correct, but really and truly, we see about 30% and higher, sometimes lower, of the population in conditions where subjective effects can have an effect. So not in cancer, but in hypertension, not in, you know, COVID-19, but in depression, in irritable bowel syndrome. So even though placebos have this tremendous utility and this tremendous potential, they really still entered the mid 20th century as being deceptive and unethical. Why? Because people believed that you couldn't administer a placebo without deceiving the patient. And by the time we get to post-World War era and into the 70s, we have medical ethics comes into play and says you can't give a patient something if they don't know what it is. It's unethical. So let's fast forward to today. Clinical trials are being done using placebo controls. And I think to great effect. Clinical trials are used to determine if a drug is safe and if it's effective. But in the last 10 years or so, what we're seeing is that the placebo response, it's not necessarily that it's increasing, and there's a lot of debate about whether the drugs are not effective or placebo responses are increasing. And on the left, you might say that that the drug effects are going down and the placebo responses are increasing. It's hard to say what is really happening, but the bottom line is what is happening is that clinical trials are failing, and they're failing for many different conditions. And drugs that have the potential to have some effects are not available. And I would say that we have a bit of a crisis for conditions like Alzheimer's, Parkinson's, pain, depression, in these conditions where we see high placebo responses. And so over the last 40 years, we've started to really ask the question, well, what is really happening in the brains or the bodies of people who are responding to placebos? And around the 1970s and through the 1990s, we started to understand that placebos are having biological, physiological, neurological effects. And on the left is one of the earliest studies conducted by Howard Fields, where he demonstrated in a series of studies leading up to this, that with molar tooth extraction, a very robust placebo response, if you gave the patient an injection of saline or a saline drip, and if you gave the patient naloxone, you could block the placebo analgesia. So what that meant was that opioid signaling perhaps was involved in mediating placebo responses. And Benedetti later on did a similar study to replicate that. And since then, we've seen several studies that really demonstrate that opioid signaling is involved in mediating placebo response. And enter the 2000s, we start to be able to do neuroimaging and use PET and fMRI to really dissect what is happening in the brain when a patient is exposed or a person is exposed or given a placebo. And this is the very elegant study that was done by Bingle et al. And what they did was they basically, and I should say this is how many studies of placebo analgesia are done. Subject is placed in a scanner and is basically given different types of treatments with information that kind of changes their expectation of what the treatment will do. So let me walk you through this study. Subjects were placed in a scanner and they were given a painful stimulus, heat pain. And they basically first, if you look at this graph here, measured the subject at baseline and asked them what was their rating of the heat pain when it was administered. And here, the subjects on average rated it at 65. And then they started remifentanil intravenously, but they didn't tell the subject that it had started. And now they asked them again to rate their how much pain they're experiencing, and there's a slight decrease, a significant but slight decrease in pain. So basically, the difference between their rating here and here is that they have remifentanil on board. Now, then they tell them, we've turned on the IV and asked them again the pain rating, and now you can see it's significantly lower. Now they're expecting to have less pain, and they have less pain. And then they keep the drip on, but they tell them that they no longer are getting the powerful painkiller, and well, lo and behold, the ratings go back up to baseline. What's really wonderful about these studies is they can follow what's happening in the brain while they're doing these different maneuvers. And what we started to see is that there's specific regions of the brain that are activated or inactivated in these kinds of studies in this one, the anterior cingulate cortex is one of the key areas that is being activated. And the next slide kind of shows a summary of much of what we're learning. I'm not going to go into the details of the last 20 years of neuroimaging that's really shown us the different areas of the brain that are active in placebo analgesia. Here is a map that kind of shows some of the areas and how they're interacting with each other. Suffice it to say that the current hypothesis, or one of the most popular current hypotheses, is that what is happening is that there are areas of the brain, whether it's the anterior cingulate cortex or the ventral medial prefrontal cortex, that are involved in making meaning or processing expectation, are actually doing a top-down modulation of incoming pain signals and basically attenuating incoming pain signals based, or you can also amplify them based on the information that you're getting. So we've started to really understand the neurological underpinnings of placebo. And what's really fascinating about this is work by Buchel and Torwager and others that basically shows that the precision of our expectation can modify the experience of what we're being told. So if I condition you and give you a broad range of signals to tell you, like, sometimes this cream that I'm giving you is going to, or this IV drip that I'm giving you is going to give you a much protection or less protection, depending on what signals I feed you to condition you, I get a more or less precise placebo response. And this is a wonderful area of research, and I'd love to talk about more. But it's suffice it to say that we're learning a lot about how the brain works when we're given a placebo. This concept of expectation, though, is quite fascinating. And here's two wonderful examples of how powerful expectation can be. On the left is you may know this prank that happened in Hamburg in 2014, where older kids at the school were leaving and gave the younger kids drinks, sodas, and spread a rumor that the sodas were spiked with alcohol. And kids were, of course, suddenly intoxicated, inebriated, had to basically go to the hospital because they were nauseous and dizzy, only to find out when they tested the drinks that there was no alcohol at all. In a similar story, here is a builder who jumped down. He jumped down on this 7-inch nail that went right through his boot, and he was in excruciating pain. When they took him to the hospital and removed the boot, they found that the nail had only gone through the toe, between the toe. It didn't penetrate the skin at all. And obviously, he was remarkably better after he received that information. Similarly, there's a really wonderful study done, again in 2014, by Ted Kapchuk and colleagues at the Beth Israel Deaconess Medical Center and Harvard Medical School. And what they did was they looked at labeling, which is a form of a way to shape your expectations, and how labeling affected placebo response. So they took patients with migraine, and they took Maxalt, which is a very effective migraine treatment, and placebo, and they labeled the pills either placebo. They labeled the placebo pills either placebo, Maxalt, or they ambiguously labeled them. Or they took the Maxalt pills and labeled them placebo, Maxalt, or ambiguously labeled them. And they asked them to rate the effects of these treatments by, a few of before and after the migraine, got acute. And what we saw here was, if you had no treatment, there was really no difference. You saw this increase in pain. But placebo labeled as placebo was a little bit effective, but nowhere near as effective as Maxalt labeled as Maxalt. And these are statistically different. But max salt labeled as placebo and placebo labeled as max salt were not different. So here again, we see how our expectations and how information guides our experience. And in this case, you can think of this as guides a placebo effect, but nocebo effects are never far behind. And there's a huge field now of statin denialism. Despite the tremendous benefit and reduction in cardiovascular disease that we've seen among people who use statins, there are a whole cadre of people who are pushing this belief that statins are harmful. And I just took some excerpts from one of these websites called Instinct-Based Medicine by Dr. Leonard Coldwell. And he said, it's mass murder. It always leads to hardening of the liver. It cuts off at least 20 years of your lifespan. And another line from him, your brain is made from cholesterol. Statin is a cholesterol lowering drug. So if you want to have a brain that's the size of a marble, keep on taking them. So unfortunately then, we have a lot of people who are taking statins having tremendous side effects with statin use, which is inhibiting or reducing the rate at which people use statins. And if this sounds familiar, because this is what we're seeing with the COVID-19 vaccine, we see this in many different places now, where negative information is seeding side effects, which then reduce adherence to treatment. One of the ways that the clinicians have been trying to address statin denialism in this case is to take a group of patients, and in this study, 60 patients that could not take a statin were enrolled in the study and were given either a statin, placebo, or no treatment, and were randomized individually to the order in which they took those. And then when they looked at, and they were asked to rate their pain and their side effects. And what you see here, the red dots are, this is on the y-axis is your mean symptom score, pain and other symptoms. The blue dots are placebo, and the white dots are no treatment. And as you can see here, after you do the statistical analysis, there's no difference between the pain that people, or the side effects that people experience with placebo versus the side effects that they experience with the statin. And literally, they were able to share this information with the patients in the study, and half of them who completed the trial were able to go on a statin. So placebo effects and nocebo effects show up in clinical trials, in clinical medicine, and I think are an integral part, not just of clinical trials and medicine, but popular culture. So I want to shift gears a little bit and talk about how can we predict placebo responders, and do genes modify placebo effects? Can we use them to predict who's a placebo responder? And can we really use, if drugs can modify placebos, can we really use our modern approach to clinical trials in which we compare drug to placebo? So this is the focus of my work. I'm very interested in understanding whether or not we can use genetics to predict placebos and what that tells us about placebo effects. So we started off, by using a clinical trial in which patients were randomized to a wait list, so they got no treatment, to sham acupuncture, which is basically a trick needle that when you tap it on the skin, it goes up into the shaft. It doesn't, like the Virum needle, go penetrate the skin. Or sham acupuncture plus a warm, empathetic, and confident clinician who listened actively to the patient, who had 20 seconds of thoughtful silence, and who had physical contact with the patient by feeling their pulse. And when we looked at this trial, what we saw when we looked at this study was, of course, as you would expect, this augmented treatment was much more effective than being on the wait list. And sham acupuncture was better than being on the wait list, but not as good as having this warm, caring interaction. And so we wanted to take this study of 104 people and ask, could we find any genetic markers that would be associated with these treatment outcomes? And because we knew that opioid and dopamine signaling from the neuroimaging studies was important in placebo response, we thought we would try working with candidate genes to look at this question. And one of the first genes that we looked at was the gene that encodes this protein called COMT. And COMT, or catechol-methyltransferase, is an enzyme that basically breaks down dopamine, which is a catecholamine. That's why it's called catechol-methyltransferase. Breaks down dopamine, epinephrine, norepinephrine, and catechol-estrogen. And dopamine had by this time been implicated in placebo response and placebo analgesia. And there's a really interesting genetic polymorphism in COMT in which there's one change. A G nucleotide is changed to an A, but this change has functional effects. So whereas the G version encodes a valine amino acid at that particular location and has very high enzymatic activity, the A version has low activity and encodes a MET protein, that MET amino acid at that location. And so you have this low activity form. And the reason why this is a very interesting polymorphism is because it's very common. And so about 50% of people have one copy of each and are called Val-MET, if you will. And another 25% of people tend to be Val-Val, so have the high activity form, which breaks down dopamine very effectively, so they have less dopamine. Or the MET, or homozygous for the MET-MET form, which another 25% of the people, the remaining people, and so they have more dopamine and more epinephrine or norepinephrine. So here we have this kind of biological experiment that has titrated the levels of, in this case, dopamine. And we asked the question, if we go back to that clinical trial that was in irritable bowel syndrome that I just showed you, and we compare patients by their COMT genotype on the waitlist arm, so no treatment, we don't really see anything happening. When we look at whether or not they got sham acupuncture, we start to see a difference, but it's not significant. But when we look at the augmented treatment, we see that the participants, the IBS participants, have a improvement, a significantly greater improvement in their symptoms with sham acupuncture plus this warm caring interaction compared to the Val-Val patients. And we recently replicated this, and this manuscript is in press, where we saw that, again, with this time with sham, with placebo pills, that the MET-MET IBS patients have the greatest placebo response, and compared to the Val-Val subjects. So basically what this is saying is that the more dopamine you have in IBS, the greater your placebo response compared to the people who have less dopamine. So we were very excited about this finding, and we wanted to look at every single clinical trial that had data on this COMT genotype. And when we started to look around, we found that the Women's Health Study, which was a randomized clinical trial of cardiovascular disease prevention using aspirin, vitamin E, or placebo, when we asked the principal investigator of this study to take a look at COMT, we were surprised to see a statistically significant difference between, and this is all women, by the way, so MET-MET women on placebo had a higher rate of major cardiovascular disease compared to Val-Val women on placebo. And I should point out to you, I just said that the MET-MET women had a greater placebo response in the IBS study. And here we have, in this Kaplan-Meier curve, that looks at the rate of major cardiovascular disease, which is stroke, myocardial infarction, or death from any cardiovascular disease cause, over the 10 years of this study, you see that there's a higher rate for who we thought would be our placebo responders, the met-met women compared to the val-val women. And I should add, and the val-met people were in between, I should add that the cardiologist pointed out that COMT not only metabolizes dopamine, it also metabolizes epinephrine and norepinephrine, and those are stress hormones. So met women might simply just have higher levels of stress hormones and are benefit more and have therefore a higher rate of cardiovascular disease compared to val-val women. So this might just be about natural history of cardiovascular disease and have nothing to do with placebo effects. But then we asked the question, well, in the women's health study, what they found originally was that there was no difference between the placebo group and the aspirin group when they looked at the rates of major cardiovascular disease. This p-value is 0.13, and what this relative risk score it's showing is a reduction of 9% in the aspirin group versus the placebo group, but it's not significant. So we asked the question, well, if you look at met women on placebo, what happens if they took aspirin? Did they benefit from aspirin? And the answer is yes. Statistically significantly differences were found between met women on placebo versus met women on aspirin. Well, what about the val-val women? We saw that the val-val women had the lowest rate of cardiovascular disease, but look at that. When we looked at the val-val women on aspirin, we saw that their rate of cardiovascular disease had gone up significantly. And the p-value for this gene-drug interaction was very significant. So then we went back to the literature and we asked the question, how many clinical trials can we find that have some gene that they're looking at and also data on the outcome in the placebo arm? And by doing that, we found 48 studies. And so there were 28 different genes. So not just COMT, but 28 different genes had been found to have differential effects in the placebo arm of these trials. And so we wanted to try and make sense of this. So we used this wonderful tool called the interactome, which is the network of all protein-protein interactions or known protein-protein interactions. And we asked, what happens if we look at those 28 genes from the literature in this network? Do they form a cohesive module within the network? And we did indeed find that they mapped to this cohesive module that we named the placebome. And when we looked at the characteristics of the placebome, what we found was they mapped very close to drug targets. They mapped very proximal to, interestingly, to drug targets of conditions where you do see oftentimes a high placebo response. So pain, depression, Parkinson's, and depression. So then we asked the question, well, are there other potential drugs that might be influenced or might influence this link between placebo genes and drug targets? And when we take a look at these studies in the literature, what we start to see that for COMT, yes, there are differences in the placebo arm compared to the drug treatment arm when we look at who responds to, in this case, tolcapone for COMT. In this case, for clonidine, we see, again, differences in the placebo arm compared to the people on clonidine. And when we start to look at other drugs, we see that here is paroxetine, Paxil, an antidepressant, that is metabolized by COMT. And similarly, phenytoin, which is another drug used in to control epilepsy, we see also that COMT is a mediator of metabolism of phenytoin. So these are locations or drugs that are potentially susceptible to having differential effects in the drug arm and the placebo arm of a clinical trial. And you might be wondering, well, what does that mean? Well, when we look back here, remember that the outcome of the women's health study was that there was no difference between the drug and the placebo. But when we use pharmacogenomics, which is what using genetics is to look at response, we see that actually there are differential outcomes depending on what subset of the population you look at based on genetics. And these differences differ not just in the drug treatment arm and in the placebo treatment arm. And I should say that we have now looked at over a dozen clinical trials, and we see this kind of effect where we see differential responses in the drug arm versus the placebo arm based on COMT and other genes. And we think this is really important, and that pharmacogenomics, or what we call system pharmacogenomics, should be used when we're thinking about who responds to a drug in a clinical trial, so we don't have as many failures as we're seeing. So I'm going to switch gears a little bit to go back to this problem of clinical trials, where we have such a strong placebo response in these clinical trials. And one argument might be, well, if you can't beat placebo, why not use placebo? But as I mentioned to you, there's a strong belief that you can't tell people that they're getting a placebo, it would ruin it. And so at Beth Israel Deaconess Medical Center and Harvard Medical School, led by Ted Kapschuk, there's a group that is asking this question: can we give people a placebo and tell them it's a placebo, create an honest placebo, and see an effect? Now, what's compelling about this is, if you think about it, why would a placebo work in a clinical trial in the first place? It's because the patient likely has a story in their head, an expectation that they should have benefit if perchance they're randomized to the drug. They could also be thinking that they're finally taking care of their treatment, and so they should have an effect because they're in a clinical trial. And it's really hard to discern all of these factors. I know for me, I was very interested in being a participant in a clinical trial, and I signed up for a trial for insomnia. And I was so excited. I thought, oh my gosh, I'm finally going to start to get some sleep at night. And, you know, and I'll call my brother, I'll call my sister, I'll be, you know, a much better sibling. And I thought, I was driving to work at the time, and I thought, let me just call my brother now. My brother picks up the phone and he says, what's going on? Are you okay? And I said, yeah, I'm fine. You know, I'm going to be doing a trial on insomnia, and I'm so excited because I'm going to have more rest. And I realized in that moment that I had already started to get better. Not only had I started to get better, but I never even got into the trial. And my insomnia was greatly improved. So I think there's a lot to be said about what is the story behind the drug, behind the treatment, behind the actual pill or the needles. And what is the drug that you're being told as a patient, and what is the story that what is the story you're being told, what is the story that you're hearing? Suffice it to say that several studies have now been done. Here are several studies in sleep, cancer-related fatigue, IBS, depression, migraine, that have shown that you can give somebody a placebo, tell them it's a placebo, and actually have some benefit. Interestingly, there's some studies that you know, it doesn't really help. Wound healing doesn't help if you give somebody a placebo and tell them it's a placebo. This concept of open label placebos is, you know, of course, no talk nowadays would be complete without some reference to Amazon. And you can go on Amazon and buy Nocebo, which is a placebo pill. And, you know, here are some testimonials that are stating that it's very effective for some people. And interestingly, there's a whole new field emerging in digital therapeutics, where apps are being built to basically replace pills. And this is being done for addiction and other outcomes. And I think what's interesting here is the app the placebo, or is the app the treatment? And what will we use as controls to control for the potent effects that we're seeing with many of these digiceuticals? So I think that, you know, it's really important to think about how we can use this powerful effect in clinical medicine and clinical practice. a group of placebo researchers did this wonderful paper, and as did Kolloquium and Barsky recently in the New England Journal, really spelling out some of the important factors to consider in the clinical setting. The clinician should ask what drives their own expectations so that they can really process them and not use them to modify the expectations of the patient. And they ask them to ask why they're assuming what they're assuming and to describe the treatment in a very positive way, to explore what the patient expects and to address some of the expectations. Instead of saying, 10% of people have a side effect, say 90% of people have no side effects. And really think about how is information conveyed in the clinical setting, and can it be shaped and framed in a way that we can maximize placebo effects and minimize nocebo effects. So looking ahead, I think I've shown you that placebos were once used as a treatment, and with evidence, they can be used again in the clinic, potentially. I think I've shown you that there's an underlying biology of placebos through pharmacological studies that demonstrate that naloxone can block overdose, naloxone, which blocks overdose to opioids, can also block a placebo response. And I've shown you some evidence that neuroimaging has identified specific regions of the brain that use opioid, dopamine, and now other types of signaling to activate a response to placebo treatment. I think that placebos, as they are used in several clinical trials, are really causing a challenge to new drug development. And we don't want patients to be charged a lot of money for a treatment that doesn't work. And certainly if you look at what's happening right now with this new Alzheimer's drug, where there was no clear demonstration of efficacy, but the FDA has gone ahead and approved it, and now there's a big debate about why insurance companies should pay for something that doesn't work and pay a lot of money for something that doesn't work. But at the same time, patients are calling for this treatment because there hasn't been a treatment that's been approved by the FDA since 2003 in Alzheimer's. So, we're taking several innovative approaches, whether it's open label placebos, and they have some promising effect in clinical trials. And we're actually even thinking about applying to the FDA to make open label placebos a type of treatment. And we started to use genetic biomarkers to understand, is there a differential effect in the placebo versus the drug treatment arm when we think about this as a systems pharmacogenomics process, and we think of it as a potential new frontier. So with that, I'm happy to take any questions. I have to acknowledge, I have amazing colleagues across the Harvard Medical School campus, and also in Germany. We've kind of delved even deeper into the cardiovascular disease pharmacogenomic question with guanylate cyclase, which I didn't talk about today, but I'm happy to talk about if someone is interested. And in Norway, Verga Grunwalder was the PI on the clonidine study that we looked at and saw these differential effects in the placebo and drug treatment arm.